going to talk about the fifth cranial nerve, the trigeminal nerve. The fifth cranial nerve. The fifth cranial nerve is important. It is both sensory and motor. But the sensory part is very important. We will look at the sensory part first. Now, when you look at the sensory part, you know that the trigeminal nucleus has three different areas that are supplied. It supplies your face, the uppermost parts, the ophthalmic division, then you have the maxillary division, then you have the mandibular division. So those are the three areas: V1, 5.1, 5.2 and 5.3. These are the three divisions. So you get sensory supply from these three divisions. Then you have differences depending on the modality you are bringing. And depending on that, you have three different areas of the nucleus that will receive these special modalities. If you look at the trigeminal nucleus, nerve nucleus, it is very long. It extends from the midbrain, which we call the mesencephalic nucleus, to the pons, the main sensory nucleus, to the medulla, up to the C2 level of the spine. We call the whole thing the spinal nerve. So the mesencephalic in the midbrain, main sensory in the pons, spinal nerve in the medulla, as well as the C2. So, what are these modalities and what's the difference? So, in between, another important thing is you have a ganglion called the trigeminal ganglion, where you have the cell bodies of two different modalities. The trigeminal ganglion. We also call it the Gaussian ganglion. What is it? The Gaussian ganglion. So, you have the proprioception. Proprioception from the extraocular muscles and the muscles of mastication going to the mesencephalic nucleus. The light touch and pressure going to the main sensory nucleus in the pons, but pain and temperature going to the long spinal pathway. And another important thing, light touch pressure, then pain and temperature, these are traveling via bipolar neurons. But this one is going through a unipolar neuron where you have the cell body only in the mesencephalic nucleus. But these ones have bipolar nuclei. So then you have the nuclei. From there, you form the trigeminal nucleus. Everything together forms the trigeminal lemniscus, which actually crosses to the contralateral side. In the opposite side, the trigeminal lemniscus goes up to the thalamus. Which part of the thalamus? The ventral posteromedial nucleus of the thalamus. And from the thalamus through the sensory cortex via the internal capsule. So this is the pathway of your sensory component of the trigeminal nucleus nerve. You have the three divisions. You have three different modalities. You have two different types of neurons. You have three different types of nuclei for each modality that you are bringing. Then it all combines together, crosses to the contralateral side, forms the trigeminal lemniscus, goes to the thalamus to the sensory cortex. Then the motor component. It comes along with the mandibular division of the sensory part. So the motor brings motor components to the muscles of mastication, the tensor tympani, tensor belli palatini, anterior belly of the digastric. So these are the motor supply. Again, the motor nucleus is present a little bit medial to the sensory nucleus, and it gets supply from bilateral cortex, motor cortex. So it's the same as a normal motor nucleus. Important thing is you have to know the muscles that it supplies. So, how do we check for a trigeminal nucleus lesion? The lesions can be in different places. It starts from the pons, so it can be a pontine lesion. It can be somewhere in the roots, the sensory roots coming out from the pons in the roots. When it is compressed by arteries, we get trigeminal neuralgia, a very painful situation where you have pain along the trigeminal dermatomes. Then you have post-herpetic neuralgia. This is very important. When you have chickenpox. Sometimes when your chickenpox is cured, you have a dormant virus, herpes zoster virus. We call it shingles. So it can activate in one of these dermatomes. Sometimes in the ophthalmic division, you have a lot of vesicles and you have very severe pain, neuropathic pain. We call it post-herpetic neuralgia. Those are the lesions, common things, very common things. There are many other lesions as well. Then you have, how do we check for this? The corneal reflex and the jaw jerk. These things you will learn in detail when you're doing the practicals, how to do the corneal reflex and the jaw jerk. Remember, in the corneal reflex, we are just touching the cornea with the cotton wool. In this case, the sensory supply, the sensory afferents are from the trigeminal, and the efferents are to the orbicularis oculi through the facial nerve. Jaw jerk, the afferents are from the trigeminal mandibular division, efferents are from the mandibular division motor to the muscles of mastication. So it's purely checking only the trigeminal. Horny reflex checks both the trigeminal as well as the facial nerve. Okay, that's it for the trigeminal.